Hello, my name is Dr. Obina Maname, neurologist with New England Telemedicine, providing care at Millinocket Hospital. I'd like to discuss a clinical case with you today. And the case is about a 35-year-old gentleman with headaches. He has a history of tension-type headaches. He says they're rather rare, but now he comes to the office complaining of a new, different type of headache. He describes intense throbbing around the eye on the right. He says the headache can last almost in what is described as a cluster, 7 to 10 days of severe headaches. He said they resolve on their own. Sometimes treatment is minimally effective. He describes them as very different from his typical tension type headaches. He has no aura, he has no nausea. He has some nausea but no vomiting, and a little bit of light and sound sensitivity. In general, he's a healthy young male. He has no other issues, just takes a multivitamin, and is an avid exerciser, likes to do CrossFit, high intensity workouts, has some history of migraine in his family, but otherwise pretty unremarkable. There is a history of an aneurysm in a aunt, so that makes him a bit nervous about his headaches. When discussing issues with him, he appears to have good headache hygiene. He stays well hydrated and he gets good sleep. He only uses caffeine on a limited basis with no overuse and no rebound. He has a little bit of neck pain, which is mild to him. On further questioning, he said he had a car accident in his early 20s, and since then, every so often he will tweak his neck, he describes, but nothing serious. On his exam, it's largely unremarkable. He still complains of that severe pain that radiates around the right eye, but his neurological examination is largely unremarkable. The only notable finding on his exam is a little bit of tenderness in the neck. Palpation in the lateral aspect of the neck does result in a little bit of tenderness. He says there's some restricted range of motion with rotation horizontally and also vertically. So in this case, the question with headaches common times is there a reason to do further imaging? Everyone comes in, it seems like, with a headache and wants to get an MRI scan or has a family history of aneurysm or something that makes them want to get an MRI to rule out something serious going on. So in general, the red flags that neurologists think about in terms of headaches are listed. Acute onset thunderclap headaches can sometimes be a sign of intracranial hemorrhage. Pituitary apoplexy or more severe headaches. Headaches with increasing frequency and severity oftentimes can make you think about mass lesions and headaches and lesions that increase and occupy space in the intracranial space. Headaches with other signs of systemic illness, such as fevers and chills, will make you think of sinus thrombosis or meningismus and meningitis. Headache with a change in character from prior headaches is also a reason to consider imaging. And then other things that we think about are focal neurological deficits, papilledema on fundoscopic examination, as well as jaw claudication, temporal tenderness, which makes us think about other headache syndromes. So knowing that these are some of the red flags that we associate with headaches, the question is there any need for further workup in this case? Based on his history, it sounds like he has a history of chronic tension type headaches, but this has changed significantly. So for that reason, and that he's a young gentleman without a very strong headache history, further workup is warranted. So the test that would be most useful for him would be MRI of the brain. Because of some of the temporal and pain around the eye, inflammatory markers can be helpful to rule out more serious problems such as temporal arteritis, although he does not really fit the demographic, period. Vascular imaging was performed, typically having multiple first-degree family members with aneurysm as the indication for vascular imaging to rule out aneurysm. But because of the severe onset of headaches and the persistence with neck stiffness, an MRA was ordered as well as the MRI, and these tests were normal, as expected. And the question, based on the description of the headache and the normal imaging, is what is the diagnosis? And what the diagnosis for this gentleman was actually called a cervicogenic headache, which is a very under-recognized cause of headache and facial pain. In general, the concept of cervicogenic headaches is that patients with neck problems, whether it be arthritis from a whiplash injury, chronic degenerative changes, can oftentimes develop trigger points in the paraspinal muscles and sternocleidomastoid as listed here on the screen. And then they can have resultant head pain in several atypical distributions. In particular, many patients have a sense of this pain radiating around the eye and into the face with facial numbness with cervicogenic headache. Oftentimes there are triggers and extra stress on the system in the neck can exacerbate symptoms, and that leads to the perception that this might be something like a cluster headache with its presentation around the eye and clusters of symptoms. In general, this does not meet the features for cluster headache because of the lack of autonomic dysfunction. In general, you need to have eyelid edema, ptosis, tearing, or lacrimation from the eye or the nose to meet the criteria for cluster headaches. And without those, you cannot make that diagnosis. Migraine headache is always within a differential. And in this situation, I think there are features that do fit with a migraine in terms of having some nausea, light and sound sensitivity. But in this situation, there's an alternative explanation for the headaches, and he does not have an aura. It'd be atypical for him to develop migraine headache at this age with a history of chronic tension headaches. So, and also, it also could make sense to treat him for a migraine empirically, and if he does not have relief with empiric treatment for migraine, then cervicogenic headache can always be a secondary diagnosis to explore. The normal ESR and CRP effectively rule out temporal arteritis as a potential cause for the headaches. And cerebral aneurysm, other space-occupying lesion, hydrocephalus are all ruled out by a normal MRI. The pitfall of ordering MRIs for patients with atypical headaches or with headache syndromes is that you oftentimes find abnormalities that lead to further concerns. You commonly will see small vessel ischemic changes on the MRI scan that are age-related, but we typically see MRI reports read as patients having possible demyelination, vasculitis, or other inflammatory processes in the brain, and these oftentimes lead to more concern for patients and more workup for the patient to undergo. So we always try to use caution when ordering MRI scans, understand that sometimes you do identify more issues than you need to deal with. So it's important to be selective in terms of choosing to use MRI scans for patients with headache. So what's the best treatment? And listed are several options. And for me, with this description, option E would be the best treatment option, which is a Medrol dose pack and muscle relaxer. Oral Imitrex is appropriate for migraine headache, but actually it's not the indicated treatment for cluster headache, which would be injectable Imitrex. Prednisone 60 milligrams a day would be appropriate for temporal arteritis, and Topamax would be the best use as a preventative for migraine, and also can be used as a preventative for cluster headaches. And also a DHE infusion protocol is not appropriate in this patient, as that's reserved for patients with status migrainosus or constant migraine headache. So what's the next step in clinical care? Listed are the options. And for me, formal physical therapy is the best option. Oftentimes patients with cervicogenic headaches require just simple maneuvers in terms of postural changes, rehabilitation, and can have significant improvement in symptoms without pursuing expensive interventions. MRI of the cervical spine to me would be reserved for refractory patients, and I think at this point the patient has not undergone enough treatment to warrant evaluation by a pain specialist. The clinical history is not consistent with a inflammatory process in the central nervous system, so I do not think a lumbar puncture would be helpful in this setting. Patients often benefit from physical therapy, but if they're unable to do it due to work restraints or to inability to travel, home exercise programs can be developed. These can be simply doing neck flexibility exercises, or can be utilized with a home physical therapy plan. So the patient returns after follow-up. He had a significant improvement of symptoms after the Medrol dose pack and muscle relaxer, but goes back to one of his workouts and has recurrent symptoms. More headaches, radiating around the right eye. What's the next step in care? So now the patient has failed conservative therapy and likely would benefit from further treatment. Of the options listed above, I think a gabapentin trial would be the first step for me. If the patient had pain radiating down the arm in a radicular fashion, had weakness, then an MRI of the cervical spine and EMG nerve conduction study may be more helpful initially. but since there's no focal deficit or radicular pain, those would be held off as secondary. It's oftentimes important to spell out the treatment plan for patients so they understand the steps of care to know that if one thing doesn't work, there is a secondary step that can be followed. Epidural steroid injections are always a treatment option for this, but should be reserved for refractory patients. Certainly they're a tool that can be used, but it is really in most patients' benefit to try to approach these issues conservatively. Treatment options abound for treatment of headaches. Many of the same medicines that we use for general headache prevention can be used for a cervicogenic type headache. Gabapentin, pregabalin, and duloxetine all have FDA indications for treatment of patients who have cervical spine, osteoarthritis, and radiculopathy, as well as headache. So there's sometimes the first options that we choose. But also we know that the tried and true headache preventatives also have a place in treatment here. Tricyclics, beta blockers, and anticonvulsants, oftentimes trying to treat symptoms and kill two birds with one stone, if you will, can be helpful. Patients with sleep problems will oftentimes benefit from amitriptyline as it can help with sleep and headache. People who have hypertension will oftentimes use beta blockers. I find that timolol tends to be weight neutral, so oftentimes patients who are concerned about weight can benefit from timolol rather than a propranolol. Topiramate is rather helpful for headaches, can help with weight loss. For patients who do not tolerate immediate release Topamax or Topiramate, there are new extended release tablets that seem to have much better tolerability, and those are being used more often. We also know that Zonegran is a cousin of Topamax as a carbonic anhydrase inhibitor that can be helpful, and I use that in patients sometimes when they cannot tolerate Topamax. Off-label uses include baclofen, lamotrigine, valproate, and zonisamide. All these medicines have some benefits in terms of treating headaches. But oftentimes it's trying to look at the big picture and try to find a medicine that works best for the multiple complaints that our patients commonly have. That being said, headaches can be rather complicated. Sometimes they're not as simple as they seem. So whenever there's a lack of response to headaches or unclear about the etiology of a headache, it's certainly worth a neurology referral to further evaluate complaints. Based on the clinical history and the character of the headaches, we can sometimes determine if there's a primary headache or secondary headache syndrome that would benefit from treatment. We also find that people with cervicogenic headaches oftentimes have dizziness. So we often do also secondarily think about dizzy spells, unsteadiness in people with cervical dysfunction. And these patients can improve with physical therapy as well. Lastly, people who have more frequent headaches can benefit from interventions such as IV infusion therapy. So refractory patients with status migrainosus or other severe headache syndromes can sometimes be treated in those ways, and neurologists can sometimes help with evaluating those patients for that type of care. So in summary, it's important to remember that the neck can be a trigger for headaches. There doesn't always have to be a proximate injury to consider the neck as a cause for headaches, but when you see a syndrome of head pain, facial pain with restricted movement on examination, a cervicogenic headache is always something to consider. And as I said before, I will be happy to provide services at Millinocket Hospital. Hopefully this was helpful and gives you some idea of some of the things that we can offer your patients here through New England Telemedicine.